Altman alluded to, we're doing a two-part series on immunotherapy, and today sort of discussing sublingual immunotherapy and discussing the mechanism of action, some of the basics of sublingual, comparing for the audience sublingual versus subcutaneous immunotherapy, and then continuing on talking a little bit about some future techniques or techniques that are under development that we may see in the coming years. A little bit of quick background on sublingual therapy. I'll leave it to Jig to do sort of the whole history. But oral delivery was proposed in the early 1900s, and attempts were made soon after that time with varying rates of reported success. And then through the 50s and 70s, it sort of faded into the background a little bit, and there was more research, if you will, into other forms of delivery, like bronchial and nasal immunotherapy. But it sort of reemerged in the 80s, in the early 80s, and sort of at the time when people were starting to run robust trials about this. And the first sublingual immunotherapy trial was in 86 with dust-mite allergy, and it's sort of gone on from there. Since that time, there's been lots and lots of studies, which I'll show you a little bit about in a few minutes. There's sort of two large forms of sublingual immunotherapy. There's dissolvable tablets, which is what we're familiar with here. That's the only FDA-approved sort of administration system. And then there's aqueous or glycerinated liquid drops that are placed under the tongue, and those are used as well. They've also tried some non-sublingual swallow tablets, so they basically formulate them with enteric coating so that they're delivered to the distal GI tract, hoping that the lymphatic network there will allow for uptake and tolerance. A little bit about the mechanism of action. So the basic concept here is that tolerance to non-pathogenic, to foreign antigens, is the sort of typical response. It's the usual response from the gut. It's the response that we hope for. And it's only sort of when that goes haywire that we develop things like food allergies. And so sublingual immunotherapy tries to capitalize on this basis and take advantage of the tolerance that the gut affords. There's an extensive lymphatic network known as the GALT, sort of collectively, that's located throughout the gut, starting with the tonsils and sort of lymphatic areas in the posterior pharynx, and extend through much of the small intestine. You may remember Peyer's patches, sort of foci throughout the gut that allow for lymphatic uptake. The antigen-presenting cells throughout the oral mucosa are the main players here, and they're the ones under the tongue that are taking up the allergen extract that we place in sublingual form. And essentially what they're doing is, the end product is they're producing IL-10. And IL-10 is an anti-inflammatory cytokine that ends up downregulating sort of allergic inflammation, the type 2 inflammation, downregulates B-cell isotype switching to Ig and ends up increasing IgG4. This also induces like T regulatory cells, which help modify this response. There's a little bit of a schematic of this. So the top, the sort of cells here, this is the mucosa here, and you can see these little kidney bean-shaped things are allergens that are going across the mucosa, going to the dendritic cells here, which themselves are producing IL-10, but also these travel to the lymphatic tissue and end up producing T regulatory cells, seen here in orange and red, Th3 cells here, and Th1 cells, and you can see there's sort of suppression of T cell proliferation, and there's increases in IgG4 and increases in soluble IgA on the mucosal surfaces. So it's a sort of a multi-pronged effort here that leads to hopefully tolerance to the antigens that are presented. So just a few basics. I'm not going to go too much into the individual products available since we're relatively well aware, but there's 3 that are currently FDA approved. There's a 5-grass tablet, a single-grass tablet, and a ragweed tablet. They all have similar indications for specific ages and sort of similar treatment regimens. They do vary a little bit in the amount of antigen in them. Part of that is made difficult by the differences in units that are used, which Jake can discuss next week. And there is sort of dust mite formulations in process. There is one available now in Japan, starting earlier this year, and there's one that's sort of in late phase trials here that's expected to come out. There's a nice table for anybody who uses up to date. There's a nice table comparing the three different approved forms if you're interested. So I think one question we have is, how well does this work? There's been, as I was alluding to before, there's been a lot of studies performed, both for specific types of sublingual immunotherapy, but also sort of for the big picture, sublingual immunotherapy in general. And the real problem has been that these studies they're not well designed. The most recent ones are better designed. The early ones, which make up the bulk of the data, are not well designed. Most of them are very small. They're single centers, and it's been hard to compare them to each other because they've all used different formulations. They've used different types of allergens. Some are, as we see, some are single allergen types. Some are multiple, like the grasses. They are on different treatment schedules. Some are used perennially. Some are used just pre-seasonally. And they all have different doses as well, which makes it very difficult to compare them. And then the measurement outcomes have varied significantly as well. So some have been based on people sort of just reporting their symptoms. Others have been based on more on biological outcomes. And because they weren't standardized, in 2012, sort of two organizations decided to try to make some standardized outcome measures. So the WAO, the World Allergy Organization, 2012, came up with, or defined basically a total combined score, which is a symptom score and a medication score that can be used in immunotherapy trials. And they proposed that a significant outcome would be at least a 20% reduction in this total combined score. The FDA used similar or established similar criteria when they were considering immunotherapy products, and they basically are looking for at least a 15% difference with the treatment group compared to the placebo, with sort of the upper bounds being at least 0.1 from sort of indifference from placebo. So this is a 2011 systematic review, and it had about 60 trials through 2009. It included about 4,600 subjects. About a third of them were kids. It was mostly grass studies. And they looked at sublingual immunotherapy in general, and they calculated these symptom scores and then medication scores. Just a brief aside. So a lot of these use an SMD, which is typically used in systematic reviews. It's a standardized mean difference, and it's a measure of effect size when you're looking at studies that have different measures. And so the score that's actually produced is not, it's unitless. It can only be used sort of generally to get it, so the sort of gist of the effect. So a score of 0 means that the treatment and placebo have equivalent effects. And here, at least in these studies, because we're looking at we're hoping that the treatment group decreases a score, symptom score. A score less than 0 suggests that there's an improved outcome with the intervention. And there's been a bunch of people who have weighed in, and sort of the consensus is that a small effect is about 0.2, a medium effect is about 0.5, and a large effect is 0.8. So with that in mind, you can see that this study came to the conclusion that that the symptoms score-wise, there was a moderate effect, and with the medication score, there was a small to moderate effect, about split in general. When we start focusing in a little bit more, there was DeBona in 2015 did a meta-analysis of all the grass trials that included about 4,500 patients. And as you can see, this showed a much more modest benefit of about 0.28 and 0.24 for symptoms and medication, respectively. But they both were significant. And then focusing in further, in 2014, there was a single trial for the single allergen grass. This is the large trial for the FDA approved product here, single allergen product here. and this included about 1,500 subjects, so about 20% were under 18. And it actually, it used actually a different outcome measure, and it showed that there was a little bit of about a 20 to 30% improvement in symptom scores. This is sort of a standard display of the data obtained from these sorts of studies, and you can see the green bars is the pollen counts throughout the season. This sort of purpley blue-gray line above is the placebo. The placebo score, and the green line here is the intervention score. You can see there's sort of a difference here, suggesting that obviously the score was lower with the intervention. But one thing to note here, or that was noted here, is that the grass pollen count for that season was about 23 grams per meter cube, which apparently is a reasonably weak season. So it was a little bit unclear at the end of this trial whether the sort of modest improvements were because it was a weak season and neither the placebo group or the intervention group had many symptoms, or whether this was there was no difference between placebo. The people were still symptomatic, but the product really wasn't doing much. I assume they argued they did not argue that the second option. In 2015, we discussed this one. All right. So in 2012, there was a study for the 5 grass pollen. This was a little bit smaller study, and it improved about 30%. So you can see all these studies are somewhere in the 20 to 30% range in terms of symptom reduction. One interesting finding about this study that was widely cited was that in order to get into this study, everybody had to have a positive skin prick test. But the IgE was measured for everybody coming in as well, though it wasn't used for enrollment. But about 10% of those with a positive skin prick test had a negative IgE level to Timothy grass. And those patients were asymptomatic during the grass season. They found really no benefit compared to placebo. And so there was a little bit of a question of testing, of technique, of our limitations in identifying patients based on this. I'm not going to go through the data.
I hate to interrupt you. I'm getting some feedback from our outside audience that they don't see the slides. So I'm telling people to look at what was sent yesterday and keep listening to you. So if you just can indicate verbally what slide you're up to,
sure.
what the header is.
Sure.
Okay.
So I'm on the ragweed and dust mite slide. I'm not going to sort of go through the data for each of these individually. It gets a little boring after a while, but the stories are relatively similar. The ragweed, there's been a handful of studies showing the reduction of symptoms by about 20%. Dust mite studies that have been that are for sort of either approved products or products that are being approved reduce the symptom score by about 20%. So it's very similar among. It seems to be similar among most of the products. So next slide. What about drops? So some practitioners use drops, either aqueous or glycinated extracts for immunotherapy rather than the sublingual tablets. And there's actually been a good number of studies, and there's been systematic reviews. There was one in JAMA in 2013 that sort of considered all of these studies. And they actually have it. They have a good number of subjects, and the data looks promising. But there was a lot of concern that, again, this inconsistency and heterogeneous reporting throughout all of these studies. Most of them didn't use sort of the agreed-upon outcome scoring for the studies. They all used a variety of different units that are very difficult to compare to each other. The doses were significantly different. There was one remark in here that for the house dust mite drop studies, there was a 50 times difference in the dose between the lowest dose and the highest dosed products, and both of them showed positive outcomes. There's differences in the potency and the treatment schedules, et cetera, and there was sort of small sample size. It wasn't really clear who was involved in these studies. So the authors here concluded that while the studies maybe, or the product maybe shows some promise, the studies to date really, nobody wants to hang their hat on the outcomes of this. Here's maybe a little bit of the meat of the talk, and what most people may be interested in is how does sublingual immunotherapy compare to our usual subcutaneous form? And the reality is that there's very, very few trials that directly compare the two of these. There have been a handful. The first one in 20 adults was in '96. These were grass-sensitive folks, and they actually used drops. They didn't use tablets versus subcutaneous, and there was about a 50% reduction in symptoms reported in both the groups after a year. But when they looked at sort of IgG4 levels, there was only an increase in IgG4 in the subcutaneous group. A later study in 2004 used about 60 adults with birch allergy. Again, they used drops, and there was no difference between the subcutaneous and the sublingual forms, though there was a difference between both of those and placebo. So there was some effect. There was just no. There was effect. There was just no difference in the effect between the two.
Those studies that are using drops, are they done in other countries where it's an approved product, or is it off-label use in the United States?
Well, most of them have been in other countries.
And so, are they approved in that format in other countries? You know?
They're actually, I don't know. I don't know if they're approved for use. They tend to in Europe have a lot more products available though in general than we do here that are approved, and we'll talk about that even coming up in the future therapies. They have stuff that's out that's sort of on the horizon here. There have been a number of indirect meta-analyses considering these. This is a large one in 2012, and it included about 36 well-designed trials, about 5,800 people. And you can see that it showed a pretty good benefit from subcutaneous immunotherapy, but of 0.92, and SLIT was 0.25, and drops and tablets were 0.4. But these are just considering them individually. So I can show you here, this is a forest plot, which I recently also learned is technically known as a blobogram. And I've just blown up on the side here the randomized effects, the sort of totals, if you will, for each of the categories. So the top is drops, the middle is tablets, and the bottom is subcutaneous immunotherapy. And right here you can see the line, so the line of indifference between intervention and placebo. And you can see for the drops that the outcome is essentially kissing the line of indifference. I think the confidence interval goes to 0.02. For tablets, you have a little bit more of a consistent result. They report sort of a symptom score, the standardized mean difference of 0.4, and you have a little bit more space here between the line and the edge of the outcome. And then here for subcutaneous, you can see they found a really large benefit. 0.92, as we discussed before, is about the highest you see, with a wide confidence interval, but pretty far from zero. So a second study has been done that was a network meta-analysis. And this was sort of another method of considering or trying to compare subcutaneous versus sublingual forms in the setting of few direct comparisons. And a network meta-analysis tries to statistically infer the difference in treatments rather than just presenting the individual outcomes like the last trial did. And it's all just manipulation. So if you look here, this is a schematic of a study. So they had three different categories of trials. They have placebo versus subcutaneous forms. They have placebo versus drops, and placebos versus tablets that they had studies to directly compare. These are the solid lines here in this figure. And then using the statistical manipulations, they were able to devise outcomes for SLIT tablets versus drops, SLIT tablets versus subcutaneous, and then slit drops versus subcutaneous.
Again, go ahead and call out the header of the slide you're on.
So this is the comparative efficacy slides of slit versus subcutaneous. And so what this study showed is that like a few before, there were results for subcutaneous and sublingual individually versus placebo. There was an effect of about 0.3. But when they calculated the effect between sublingual and subcutaneous, there was no difference between the two of them. Essentially, that's what we have for data comparing the two different forms. There's, as I mentioned before, it's pretty weak, and most of this is indirect. So it's difficult to really come to a firm stance on it because a lot of this is just statistical voodoo, and likely a lot of this is because of the wide effects that we see between individual studies.
I'm just going to interrupt you for a minute. I'm curious if those in the room who prescribed immunotherapy using oral, what's your impression? My impression clearly is going back to the slide that showed much greater efficacy of subcutaneous. Obviously, having practiced this one here, practiced this way for a long time, it's my belief that there's no comparison that subcutaneous is much more effective. I know Steve Tillis just told me, I don't know where he got the data, but some of the most recent, I suspect, unpublished data clearly confirms that for grass, there's no comparison, that subcutaneous is much more effective. Anybody else want to chime in?
Well, I know personally it's a little hard to tell because I don't think over the years I have that many patients on just monotherapy skit for grass. A lot of times they're just not highly motivated, and I mean they are when they're bad in June, but they sort of forget about it and they're like, I don't want to go through the shots. But I'd say about a quarter actually bagged it with slit because of too much mouth itching, even despite taking antihistamines in January before doing it. But the others seem to have a pretty good response, but it's hard to compare.
I basically haven't had anybody do it. The road to hell is paved with good intentions. They say we'll come back in the spring 3 months early, and of course they never show up.
Exactly, because they're fine in January.
Yeah, and then the insurance companies made it hard to get. The few patients I've written for, well, you can't have it. You have to jump through the hoops of the insurance company to get it, and then it was such a bother. Didn't end up doing it, so I have 0 patients on it right now. How about the University of Washington?
I have 1.
Oh, yeah.
One.
I had 10.
10. You're the record. You've got a series.
I had 3 people. One woman broke out in hives every time she took a dose. One person started having some EOE type symptoms. And the third kid, it just wasn't effective. I saw him in May, and the parents pretty much said it did nothing. So those 3 were kind of my fails. It was interesting. I had a few patients that had been on allergy shots for many years, and then they went off of them. And the only thing that bugs them is grass. And they didn't really want to go back on shots. So I had like 2 adults, and then I had some kids because they don't want to do shots. So, yeah, I think for some of them it worked okay. For others, So.
It's interesting to me that the data, when people compare it in a percentage way, says that a good response is like about 30% reduction in symptoms. Now, I've been over the years, I just made this up, totally empiric practice, when I tell people what they might gain from traditional immunotherapy, I tell them they're going to get 70 to 90% better.
But I said 80%.
Because that's what I think I see over all these years of practice. And, I was totally shocked when studies came out and said 30% is a good response of subcutaneous immunotherapy. I still tell people 70 to 90%. I don't know, those of you who've been practicing for a long time, you even see people who become asymptomatic and stop all medication.
Well, I mean, one of the symptoms I think that a lot of the studies don't consider is just fatigue and malaise. And that's the thing I tell patients, this is going to help, the shots are going to help more for that than any of the medications you're taking. The fatigue and malaise you have during your high pollen season is definitely improved, and I believe it.
Yeah, no, I think so. I agree with In the studies in other countries where they use multiple tablets, since we don't, do they actually do that? They have people, can you tell from the articles, are they taking a dust mite tablet and a grass tablet and another tablet all together in the same day? They describe the methodology.
So all the studies that I saw, at least, were using monosensitized patients. So I don't know if in practice that's what they're doing.
I mean, I know there's a couple studies from Italy that show that if you try to do more than 2 at a time, either the patients bail or it just doesn't work, period, for anything. And I don't think anybody knows why exactly.
That was the other interesting thing. When the Europeans looked at their data, you would think if you told people you could do it at home and all you have to do is take a tablet, you'd have a high acceptance or compliance rate. It's about 20% that people stick with it. So you don't gain what you would think you would gain.
No, exactly.
Talk a little bit about the adverse effects. So overall, the sublingual forms, as we know, are very safe. The common effects, which occur in a good number of folks, is oral itching, ear itching, sort of throat irritation and edema. The study sort of suggests that most of these occur in the first week and then resolve, although the swelling can be a little bit later. But it sounds like there's definitely a good number of people out there who have persistent symptoms. There is a theoretical risk of eosinophilic esophagitis with these, and so it's recommended not to use in anybody who has EOE already, but you should also go sort of look at. In one of the reviews back there, the DeBona review, there was it also proved to be really reasonably safe. There was 12 episodes of anaphylaxis in the subcutaneous group and 1 in the slit group. And the individual in the slit group had, I believe it was thrush at the time that they were taking it, and so one of the on the package insert stuff, they sort of make it clear that it should really only be taken in the setting of an intact, non-inflamed mucosa. You shouldn't have oral surgery around the time, et cetera, to ensure that you're not having increased uptake, essentially. And that's where the recommendation for the EpiPen, maintaining the EpiPen, came from. The sort of all the products that are on the market had similar rates of local side effects. When you look at the trials, most of these studies had safety arms in them, and it was interesting because the range of these local effects was anywhere from 0.2 to 97%. So everything from nobody to everybody had some side effects from these sublingual forms. One of the thoughts in terms of the relative safety of sublingual forms is the thought that it may reflect a lack of mast cells in the oral mucosa. So there was this nice study here by Marcucci in 2007 where this is a single patient, but the top level, the A's,
You're showing pictures of the oral mucosa.
Showing pictures of adverse effects. Shows eosinophils on the left, mast cells on the right, and the top level A is prior to starting sublingual immunotherapy. And you can see there from the black arrows that are sort of hidden in there that there's about 2 eosinophils identified and 3 mast cells. And then on the bottom 2, the B's, show a repeat biopsy 3 months after starting sublingual immunotherapy. And what they're demonstrating is that there's no increase in the number of eosinophils or mast cells even after a person has been exposing their mouth to a bunch of allergen, as well as showing that the numbers in total before and after are pretty low. In terms of sublingual immunotherapy and asthma, most of the trials have included patients with either intermittent asthma or very mild asthma that have always, they're always well controlled on their inhaled corticosteroids prior to starting therapy, and that's where the FDA indications come from. There are a handful of studies out there. Most of them think that probably symptoms are not worsened in these patients, and there may be some benefit. There was a house dust mite study in folks, it was adults and adolescents with moderate persistent asthma on budesonide, and they showed that after a year of therapy, their budesonide was very slightly reduced. I think it was reduced by 80 milligrams a day after 1 year. This year there was a Cochrane review on the subject, and the Cochrane folks basically came to the conclusion that there was no useful data out there, and it was very difficult to draw any clinical conclusions from it. And then there's also there's not a lot of high quality data demonstrating sort of prevention of asthma, the development of asthma with the use of sublingual forms. So finally, discussing the persistence of the benefit, from subcutaneous immunotherapy, we know that after sort of a treatment course of a few years, there's some durability of those of the symptom benefits. With sublingual immunotherapy, the sort of optimal duration and that persistence is not quite known. There was a Dustamite trial that put people on 3, 4, 5 years of therapy, and then they reported that there was sort of persistent symptom reduction for 7, 8, and 8 years following. And the authors of that study concluded that 4 years was likely the most efficient treatment course for at least Dustamite immunotherapy. And then there was also a single grass allergen study of about 230 people that basically treated them for 3 years and then followed them 2 years after. These are some of the images from that trial and the persistence of the benefit. And you can see here seasons 1, 2, and 3 in the left-sided image show between a 35 and 40% decrease in symptoms compared to placebos during the treatment seasons. And then there's 2 follow-up seasons that show a persistence of that benefit, although that benefit is sort of declining. In the first season it was 34%, and the second season was 27%. In B, on this side, they measured IgG4 levels during the course of that treatment. And you can see during the 3 years of treatment, the sort of IgG4 levels went up. And then once off the sublingual immunotherapy, their levels fell after that. And interestingly enough, they only did 2 follow-up seasons. It would be somewhat interesting to know, where the next dot in this line was headed. I think we know where it looks like it's going. One interesting thing with this trial again is that when you look at the pollen counts for the seasons, the treatment seasons actually had reasonably high pollen counts, but as you can see that in the 2 follow-up seasons, especially the second follow-up season, the counts were much less. And so again, we go back to that question: is the smaller reduction in the second season a result of the therapy not being that durable and sort of the effects wearing off, or is that an effect of the overall lower counts for that season?
And were these people on it year-round, or were they just on it seasonally?
These ones were on it year-round.
Year-round. Okay.
Actually, that's a good point. I mean, what I've been telling people, what I think the literature says, if you just take it pre-seasonal and co-seasonal and stop, you don't really get a durable effect. You just get year-for-year treatment. You've got to stay on it year-round for 3 years to start to see any permanence. At least that's what I tell patients when they make a choice whether to go on this.
No wonder they don't stay with it.
Right.
Because the whole benefit is that you could just take it co-season. The disadvantage, if you're going year-round, you might as well go regular immunotherapy. So,
well, I mean,
but are your patients staying on it year-round? I'd be surprised.
It's too new to know. I mean, honestly.
The other way to spin it is if you look at the comparative, you're actually using less of it if you just do it for the 6 months. You know what I mean? Every year. In other words, 4 years, that would be 24 versus 36 in the first group. So, cost-wise.
Yeah, if you only have a 3-month season in this part of the country for grass.
So it's about a half a year of therapy.
Yeah, just total digression. And further, we have 2 grass products, and at least in this market, it seems to me, even though we haven't incorporated it much, we're only using the single agent. I see absolutely no promotion or interest in the other product. even though
Well, it's really
some
that one's really
companies-
hard to
That's
get.
right.
It's hard to get at the pharmacy. You have to go through a lot of hoops to get the 5 grass pollen thing, whereas the single one, the Merck product, is at the pharmacies.
Yeah, well, the
But I
other one,
think
I
that-
don't even see anybody pushing it or promoting
Well,
it.
and I think that's why the first part is true, that there's not distribution and promotion. So, did you come across anything looking at SCIT plus SLIT? Either in terms of, enhanced efficacy and the safety piece, or some patients have asked about that. In other words, obviously you can, if they're on SCIT, you can start fiddling with the constituents to try to hit what doesn't seem to be, like the grass season's still awful. But I've toyed with the idea of, adding oral maybe as well. Or
There are a few studies that do look at that. It didn't seem like there was not that much of an increased benefit, and it sort of reduced the safety profile. So they sort of concluded there wasn't much. But I don't know how robust the studies were. I don't think they were large trials.
And do you know, for the grass studies, did they only allow monosensitized people in the study? In other words, could you have tree pollen allergy?
So most of them tried to include monosensitized to keep it clean.
Because that clearly could wash things out, especially if they didn't treat the tree allergy well.
So as we sort of wrap up and talk a little bit about the future of immunotherapy, there's actually a lot of exciting things that are going on, especially in the past few years, and they sort of they touch on a variety of different methods. Sort of wrote it out here, but there was a nice image in this paper that showed sort of the various options available. There's considerations of different administration routes, sublingual being among them, but then a variety of other methods of either administering subcutaneous or injectable immunotherapy, as well as different products. So I'm going to go through a handful of them here. Peptide immunotherapy has had a lot of buzz behind it, and the concept is using short peptides to essentially induce a T cell response, but basically making them short enough that they avoid any IG cross-linking. So you have the increased safety and hopefully a response without people having effects. And the idea is that if you can sort of induce T cells with these short peptides, you can do the same process that we discussed earlier on. You'll end up increasing IL-10 levels. You'll end up thereby increasing T regulatory cells. You'll decrease the isotype switching to IgE, et cetera, et cetera. So probably the best studied one is a cat product. It's called CatPad. It's a 7 peptide mixture, or a mixture of 7 different peptides that's administered over 12 weeks. You have 4 doses over 12 weeks. There's actually been a handful of different versions of this. They had, I think, a 24 peptide version and then a 12 peptide version, and they finally settled on the 7. And a lot of that has been because of safety. They were looking at the higher peptides. People actually were having mostly asthma symptoms. They're having a response that was no different than placebo. So with the 7 peptide one that they now have, the safety profile is much better. They show, so they've done a handful of studies here. One showed sort of the initial study basically gave the 4 doses over the 12 weeks, and then a year later stuck people in like an immersion chamber, and they showed that there was durability of the results, so there was a difference between compared to placebo. And then they did a 2-year follow-up as well that showed persistence of these benefits, and that's this table down here. So they basically took people on 4 separate days and placed them in the immersion chamber for 3 hours, and then they reported their symptom scores. The green is the folks receiving the intervention, and you can see that their change in their symptom score is greater than the folks who were placebo alone. So there's been some good data. I think it's ongoing. I don't know exactly where the product is in terms of where they are in terms of consideration of bringing it to the market. It sort of fell off, and I haven't heard any more information about it. But there's some encouraging data there.
When you say 7 peptide, you mean one peptide of 7 amino acids or 7 distinct peptides of cat allergen?
7 distinct peptides of various forms. So they basically take that cat antigen. Essentially, the concept would be is that they break up parts of it that are recognized by T cells. Would sort of be the most basic format. So enough. The peptides have to be essentially long enough to be recognized as the specific. They have to be specific still, but you want them to be as small as possible so that you obviously don't cross-link. And so what they found is that by using a number of different short peptides that are all reasonably specific, you get a better response than using just a single peptide that's specific. That makes sense.
Mm-hmm.
Another area of research is recombinant extracts, and there's been sort of two different types. There's a wild type one, which is essentially just creating regular extract in a lab with the concept here that you can sort of reduce contamination, you can get more consistent and standardized amounts of the extract, and you can prevent sort of new sensitizations if there's other stuff in there. One study using recombinant birch showed sort of higher IgG4 levels when compared to using sort of the options that are available on the market now. But obviously no difference in the, there's no improved symptoms compared to the products that we're already using. They've also come up with what they term hypoallergenic recombinants, and basically that's producing the same proteins but folding it slightly differently so that they don't cross-link IgE as readily. And there's been a few early phase trials that show that the efficacy is similar to the usual extract, and even at higher doses, there's no increased adverse effects compared to the usual extract. Adjuvants are another area. So there's already alum-based adjuvants on the market in Europe, and the concept behind these plays a little bit into what we think we know about how immunotherapy works. There's some idea that having the allergen around in low levels may sort of induce tolerance, or compared to having sort of bursts of exposure, which may lead to sensitization. And so, by using an alum-based adjuvant, you basically have a depot effect. The antigen is sort of hanging around longer and being presented for a longer duration, with the hope of then thereby inducing tolerance better. I don't think that the data though it's available in the market, it wasn't clear to me that the data is robustly improved compared to our usual immunotherapy.
We used to have that in the U.S. for years. This is not uniquely European. I don't know, Frank, is it totally off the market in the United States?
I think it is, yeah. Yeah, I know. Like John Tolan, that's all he gave people.
Yeah, and for decades this was a product in the U.S.
Why is it off the market? Nobody was using it?
I don't know. That's a good question.
Alzheimer's,
yeah. Too much aluminum in your brain.
You're kidding.
Well,
No,
the whole idea was it was supposed to reduce your systemic reactions,
Right.
but
Right.
it wasn't really any more efficacious, and probably I thought it was less.
The sort of newer area of adjuvant research is using Toll-like receptor agonists. Toll-like receptors are a part of our innate immune system, and we think of them as doing sort of more of an a positive immune response, going after sort of bacteria and stuff. But there's been some research that shows that it has an that Toll-like receptors, when activated, can also have an immunomodulatory effect. And this area of research tries to capitalize on that. So Polynex Quattro is a product, again, that's available in Europe, and it is MPL, which is a part of LPS, the gram-negative toxin, which is a TLR4 agonist. And they have found that by coupling GRAS essentially to MPL, that they can use fewer injections and have improvement in their symptoms. So basically, compared to placebo, they can inject this you have 4 preseason injections over several weeks, and they found that their peak pollen, the scores during the peak pollen season were reduced compared to placebo. There have been some studies that have shown durability of the symptoms for a number of years afterwards if they get sort of 3 preseason or 3 season pre-treatments. But I'm not sure, I wasn't able to find any information about where this is, if this is being considered in the U.S. or not.
These are just fixed doses. They're not titrating up.
They're fixed doses.
Mm-hmm. And it is. There's, at least for food, so the ITN is looking heavily into using TLR4 agonists in combination with OIT for food trials. We're going to possibly be a site at Asthma Inc. for this. We're also a site for the peptide immunotherapy too, both the dust and the cat. Cat's in phase 3, dust is in phase 2.
There's another interesting TLR agonist, a TLR9 agonist, and it's this thing QBG10, which is a bacteriophage essentially. It's the agonist inside a bacteriophage, and they've actually done 2 different studies. One where they actually couple this to dust mites, and the other one where they actually just give it alone. And both of them have actually been shown to reduce allergic rhinitis symptoms and asthma symptoms with 6 to 10 weeks of treatment. So basically the way it's given is 6 weeks of twice-weekly injections. And this one study looked at patients, adults, on budesonide. They basically had a running period where they were stabilized on their dose of budesonide, and then they were given either placebo or the QBG10 sub-Q injections. And after 4 weeks, everybody decreased their budesonide use by 50%. And then at 8 weeks, they reduced their budesonide dosing to 0. It's sort of interesting. So the top two graphs here, figures here, are the symptom scores, and the bottom one is the FEV1. The dark line, the black line, is the intervention, and the white boxes are the placebo. And what it basically shows, is that you can see over the first 4 weeks where they're at 100%, and then the second 8 weeks and the second 4 weeks and the third 4 weeks, that the symptom scores in the intervention group are relatively flat; they don't change. Whereas as the folks on placebo, as they begin to wean their budesonide, their report of asthma symptoms increases. And in the bottom panel, they tried to objectively measure this, and they measured FEV1s, and you can see that there's a reduction in the placebo group of the FEV1 as they wean their budesonide, suggesting that there's some benefit to this intervention. As I was mentioning, one of the most interesting things about it is that this doesn't have, though it works for people who are sensitized to dust mites, it doesn't have any dust mite component to it. This is just this bacteriophage that stimulates TLR9.
What's the proposed mechanism of that?
So that's very up in the air. I don't think even the immunomodulatory effects in general of Tolllike receptors are as well established. They do use, they have used that concept though in other areas as well, and so it's been known that you can induce sort of immunomodulatory effects with Tolllike receptors. I just don't think it's known how it's done. Lymphatic immunotherapy has been tossed around, and this is actually used reasonably often in veterinary practice. Apparently, one of the feline viruses they immunize into the lymphatics, and they get a good result. And then there's a few dog vaccines that I think are less typical that are used. And the thought here is that you can use smaller doses of allergen and fewer doses. And there's been some data for it. There was the initial study, or decent-sized study in 2008, compared SCIT to intralymphatic immunotherapy, and there was a positive outcome in the lymphatic group. But there's been other studies that didn't show that there was a significant difference in the symptom scores compared to to placebo or to methods that are currently used, despite there being increased IgG4 levels. So I think it's being pursued, but I think the magnitude of the effect was not quite known from what I could tell. This is one study here. So you can see on the left side here, they show you the doses, and they sort of dramatically show you the doses, the cumulative doses of allergen you get with subcutaneous immunotherapy on top, about 4 million units, whereas with 3,000 units in the intralymphatic group. And then in D over here, you can see that the subcutaneous and the intralymphatic groups, the symptom scores, symptom reduction is pretty similar. They sort of trace over each other, showing that you can achieve a similar benefit that over 3 years in intralymphatic therapy. And then finally, using subcutaneous and omalizumab, I think that that's sort of can be already in use. It's shows reduced systemic reactions. In many of the studies, it shows decreased symptom scores. One study was basically did 18 weeks of therapy, 10 weeks of build-up, and 8 weeks of maintenance of either subcutaneous plus omalizumab or subcutaneous plus placebo. And then after that 18 weeks, they transitioned to subcutaneous alone. And they found that patients had decreased symptoms when they were on the subcutaneous plus omalizumab compared to the placebo group. But once they came off the omalizumab, that difference disappeared when they were all on the subcutaneous. So the effect wasn't durable in the intervention group. This has been also used before in other forms of immunotherapy. So just to wrap up, we talked a little bit about sublingual immunotherapy and sort of the mechanism behind it. We're aware of sort of the greater safety profile, the convenience, and increased comfort for the patients. But right now, there's no option for the polysensitized. There's a lot of studies out there. They show a real wide range of efficacy. And I think the sort of bottom line is that folks feel that there's probably some benefit to it. The magnitude of that benefit is a little bit unclear. And comparing that to subcutaneous forms, that there's no great data to show one over the other. Though if you rely on the statistical manipulations, you may see some superiority of subcutaneous versus sublingual. And then there's a lot of areas. And I think that the take-home message for the future modalities is that the idea basically is to either offer improved safety, shorter durations of therapy, or more robust symptom improvement than what we have. And I think there's some good possibilities out there. We'll have to wait and see how it all pans out.
Were there any studies that looked at whether SLIT was superior just taking an antihistamine and nasal steroid? As far as efficacy, and the studies usually get 20 to 30% improvement with them as well. Is there any benefit of SLIT over just using a drug?
That's a good question. I didn't particularly look into.
I don't think anybody wants to look at that. Because my guess they'll find out it isn't superior to it.
Well, if you consider, most of them use the medication score. So if you consider the placebo group, essentially using the medication scores, then some of them clearly didn't show that significant of a difference. They didn't decrease their medication use that much.
They need to blind that part too.
Yeah, they would have to.
Okay, very good.
Any other comments from our outside audience? I have a couple of comments here. One echoing Frank's comments about most people being polysensitized, and so just being able to treat one antigen is not all that useful. And is there anyone trying to use a combination of peanut epitope and Tolllike receptors for? Dan, you want to comment on that?
That's still in the planning stage, but yeah, that's one of the ideas to be used because they're looking for any sort of immunomodulatory plus because OIT is dangerous. It's rough on people. People have awful times on traditional OIT.
I'm not sure that it's a durable tolerance.
It certainly has a bit of seen, and then it's better with Xolair, but really hasn't shown to provide any sort of tolerance yet. It improves the safety profile of the OIT, that is for sure, but hasn't really shown any sort of tolerance. Talking to Bob Wood at one of the meetings a few months ago, and he just finished his milk OIT plus Xolair and did a tolerance after, I think, 4 years of being on OIT. Took him off for like 6 weeks, and it was like 80% lost their descents. So must do better is the feeling. And ITN is looking for any sort of immunomodulatory type agent to see if we can make this better.
Well, I think they're adding like lactobacillus and other things too to see if that might tweak the.
You know, it's interesting. Those who have been at this for a long time, new things that seem more precise and definitive often don't work out. There were studies a long time ago of looking at the dominant antigen in ragweed versus just crude ragweed as a way of immunizing people. And all this elegant science was done, and just crude ragweed extract was the better of the two, as opposed to isolating, what's the name of the main antigen in ragweed?
AMB1.
So these are elegant approaches, but actually getting them to be better than just old-fashioned empiricism is often very difficult.
Well, they've been doing the peptides for decades, it seems like, and nothing's ever come of it. So,
yeah, exactly.
All right, well, next week we'll have the first half of this presentation, traditional subcutaneous and very practical questions like how do we write orders and how we ever got to where we are now in writing immunotherapy orders and so on. Jake will do that. All right, thank you very much, Andrew.
That would be your bomb.
Guys, take all the food you want.
Yeah.
Somebody dropped their phone.
That'd be me, thank you.
One box, hopefully.
Yeah, super nice. Dr. Allman, you some bags if anybody wants to follow our meetings.
Yeah.
They're brand new, just a little wrinkly. To-go bags. There you go.
Nice.
Feel free to take, Dan, you go.